having discussed the basic physiology of pregnancy, starting from A, B, C, D approach, you're going ahead with your circulatory things, which is going to be very dangerous in this group of people, because point number 1, the patient will be in physiological anemia, where the blood volume will be on the higher side. To pick up any symptoms or signs in the maternal circulation, around 1.5 liters of blood would have been lost by the mother. At that time, the fetus would have already suffered an insult. So you need to pick up this insult very early. That is with the circulation part. Understand, the heart rate will be mildly on the higher side and BP will be slightly on the lower side in the second and third weeks or third trimester of pregnancy. And any change in this, you need to consider any alteration. That is, a normal, a little higher BP, consider it's going to be eclampsia or preeclampsia, and delay in capillary refill time can be a clue of delayed perfusion. Coming back to the mechanism of injury, the motor vehicle collision forms around 49%, fall forms around 25%, assault 18%, and gunshot wound around 4%, burn injuries 1% of the mechanism of injury. If you specifically go for blunt and penetrating, the blunt injury forms around 91% of abdominal injury. In penetrating, the gunshot forms around 73%, stab wound forms 23%, and the shotgun wounds form 4%. All these things is just within this 9% only. So coming to the blunt injury, understand that the abdominal wall, the uterine musculature, the amniotic fluid all tries to save the fetus inside. Okay, tries to save the fetus inside, and this acts as a buffer to prevent any direct fetal injury. But if there is a direct trauma, like there's a steering wheel injury which directly hits at the abdomen of the pregnant female, the steering wheel can create a significant impact. Or if there's an indirect injury to the fetus by rapid decompression, deceleration, or any shearing force, this can also result in insult to the fetus, maybe an abruptio placenta also. So specifically to ask about the seat belt, okay, there are a lot of concerns about how really to wear a seat belt. Should we wear a seat belt or not in pregnant females? So compared to restrained pregnant women, unrestrained pregnant women have a higher risk of premature delivery and fetal death. Understand this concept. Even in a pregnancy, you need to restrain so the type of restraint system affect the frequency of uterine rupture and fetal death. So consider that the patient or the pregnant female is using only a lap belt, like only a lap belt thing. The patient is using only a lap belt. So suddenly when there is a trauma or there is an accident, an RTA, the patient flexes forwards, right? They flex forward. So when they flex forward, the uterus goes for compression and possible uterine rupture or abruptio placentae. Okay. So if the lap belt is worn too high over the uterus, if it's worn just over the uterus, it can directly compress the uterus and cause rupture. So both is wrong. So what is right? Using a shoulder restraint like this, with the lap belt reduces the likelihood of direct and indirect fetal injury, because the shoulder belt dissipates the deceleration force to the greater area, okay, towards the shoulders and the body. Okay, it stops you from bending forward at the level of the shoulders itself. Okay, so therefore it is important to determine the type of restraint device owned by the pregnant patient, if any. Okay, and moreover, the deployment of airbag in motor vehicle does not appear to increase any pregnancy specific risk. Okay, it's just an airbag just to protect the maternal life. Coming to the penetrating injury, understand, as the gravid uterus grows larger, the other viscera are relatively protected from the penetrating injury. But the likelihood of the uterus getting injured is high. Okay, the uterus grows very high. The intestines, liver, and the spleen are all pushed up. Okay, this is going to be your liver, this is going to be your spleen and your kidneys. Okay, since the uterus has grown very big, the other organ systems are pushed up. So relatively, these other organs are relatively safe, and the brunt of insult is taken by the uterus. Moreover, the dense uterine musculature in the early pregnancy can absorb a significant amount of energy from the penetrating objects and decrease the velocity and lowering the risk of injury to other organs. Not only the myometrium, even the amniotic fluid and the fetus itself can absorb some energy from the penetrating object. So, there is better maternal outcome but poor fetal outcome. This is what you need to know as far as penetrating injury is concerned. If there is a penetrating injury directly over the uterus, all these buffer mechanisms plays into action. There is the myometrium, the amniotic fluid, the fetus, everything will take the brunt of the injury along with the anteroabdominal wall. But if there's a penetrating injury above or the upper abdomen, you need to consider very complex injuries because all these organ systems are very compressed and tightly packed here. So an injury, direct penetrating injury over the upper abdomen is going to cause a very complex type of injuries. And moreover, when you palpate or examine the lower or middle abdomen, you will not be able to find out that much of a peritoneal irritation signs because most of the contents are in the upper abdomen. So coming to the assessment, understand to optimize the outcome, you need to assess the mother, resuscitate the mother, and don't go for secondary survey then. After the mother, you need to check the viability and the well-being of the fetus, and then you can go for secondary survey. So in primary survey, ensure ABCD, no doubt about it. If there is a need to ventilate, you need to intubate the patient, ventilate the patient, and make sure the carbon dioxide, the PCO2 is maintained somewhere at around 30 respiratory alkalosis need to be maintained. If the PCO2 somewhere around 35 to 40 or 45, it means that the patient is already in impending respiratory failure. She needs some kind of support, maybe an NIV, or go ahead with tubing the patient. And manually displace the uterus to the left side to relieve the pressure over the inferior vena cava. Maintain adequate oxygen saturation because even a minimal maternal hypoxia, the fetus is going to suffer. So you can see this image. Not only that you're going to make the patient lie little on the left side because the uterus is falling on the IVC, you need to decompress the IVC, yes. But if there is a need for spinal immobilization, you're thinking of a spinal fracture or a spinal column fracture, vertebral column fracture, then you need to do as shown in this picture. So if they require a spinal motion restriction in supine position, log roll on the left side 15 to 30 degrees and elevate the right side to 4 to 6 inches along with the blostering device. Okay, so this is how it is done. So this maintains the spinal position and decompresses the IVC also.